So our next speaker is Roberto Llorens. He's principal investigator and group leader of the Neurorehabilitation and Brain Research Lab at Universitat Politècnica from València. And he has been doing for years now a lot of research, mainly applied work. He's devoted to understanding how we can boost neurorehabilitation, but he does not stick to any specific method, as you will see. So he touches many different systems. So thank you so much, Roberto.
Thank you very much for the introduction, and thank you so much for the invitation. So it's a real pleasure for me to be here. Basically, I think that Belén has done a really good introduction because we did a lot of different things, most of them clinically applied. So what you're going to see is basically clinical research, or what I call clinical research, some basic stuff, but I won't be presenting this here. So, first of all, I have to say that I told you, please do a bad job because I'm going after you. And basically, you blow up my presentation because a lot of the systems that I will be presenting are really connected to some of your developments. So it's absolutely fantastic because I will be doing a lot of connection with your work. So and also with Belén's work, and with your work. I saw that yesterday. It was the talk, and then there was some discussion. Please don't hesitate to interrupt. I will be interrupting myself, so don't hesitate to interrupt me. Belén told you that I'm the PI of the Neurorehabilitation and Brain Research Group in the Y3B Institute in Valencia. That's right. But some years ago, I also the scientific coordinator of NeuroRHB, the Brain Injury Unit of BITAS Hospitals. BITAS Hospitals is it's a clinical network of different hospitals in Spain, and I'm coordinating the research that is done in 6 hospitals of the network, where the brain, which have a brain injury service. So basically, we provide clinical care to more than 500 to 600 individuals with a brain injury. It's only brain injury like stroke, traumatic brain injury, anoxia, etc., but not multiple sclerosis, Parkinson's disease, and we are really focused on brain injuries. I think that all started because we are really close to each other. It's 200 meters, which makes things really easy, as you may understand. But unfortunately, I don't know if it's unfortunately or not, but we are moving. So the hospital is moving to the center of the city, to a brand new facilities, which are supposed to be very good, but everybody's very sad. And it would make things really complicated for us, for, all these logistics. So I was wondering what to present because as I have one leg in the university and one leg in the clinical in the clinic. We tried to provide solutions to the clinical limitations. So after brain injury, so we work in different domains. As you know, that after a brain injury, you can have deficits in a lot of domains. We don't particularly work on motor or cognitive or behavior. So we're treating, all of the symptoms. So we are also doing some kind of research in all of these domains. But I chose upper limb, and now I'm happy to do that, for having done that, because as I was saying, we can do a lot of connections here. So I think that I can jump over this. Just let me highlight that. You all know the neurological basis, but numbers are amazing because they say that probably 50% of individuals after a stroke will present upper limb deficits. That means that probably 250 or 300 of our patients, will present upper limb deficits. And after 6 months, only some of them will be able to perform accurately, some tasks. So it's definitely a reason why we should be working on this. One of the topics, one of the things that we have been seeing in these talks is the severity, is that the heterogeneity after stroke is huge. So you know that each patient will present a different combination of symptoms with different intensity, and it also can be applied to the upper limb. So the severity of the impairment of the upper limb is also heterogeneous. So we will have different, as many possible strokes as many people with a stroke will have. So each stroke survivor will present a different combination of deficits, which will be doing like everything more complicated. Belen showed you a video of an individual with stroke. Let me show you how how the different severities of upper limb deficits. These videos were taken like yesterday. So let me see if they can be reproduced. Yes. So here, this is an example of a individual with a mild impairment of the upper limb. He can reach the jar, no problem. This one can't even take the jar. Good flexion of the elbow, also able to do the grasping. This is typically maybe a focal measure between 43 to 66. Let's see what is a moderate impairment. Now we will have different motor coordination problems, apraxias, problems with the flexion of the elbow, more proximal and also distal, difficulties to grasp, to produce the force, also to take the jar. And in case of a severe impairment, this is focal measure, lower than 30, typically 30 or 25, it depends on the author. When you say them, please, or try to bring the jar, or try to drink, they are not able to do it. And I'm telling you, they are trying it. We don't have the voice here, but they are trying to do it. So the thing is that they are not able even to move it, not even proximal, without compensating. So of course they can do that so they can do it, but they are not able to do it without compensating the movement. So in the clinical we can have, and this is just a picture of 3 different types, but we can have a lot of different severities of upper limb deficits, so in a different combination. But I wanted to categorize like this, like a RAF thing, like very roughly, because I will be presenting different systems, technological systems, to promote rehabilitation for each one of these patients, let's say, categories. So we all know also that one of the mechanisms for motor recovery is cortical reorganization. It's driven by neuroplasticity and so on. But then remind you probably yesterday that this happens, endogenously in the first weeks after the onset, which is believed to occur. This has been extended and extended. It was supposed to be 3 months. Now it's almost. Everybody says or agree that it happens until 6 months, and then after this period, plasticity. It is possible, of course, but this has been driven. It won't happen. It's not supposed to happen endogenously, so you have to driven it externally, which is absolutely possible, but with rehabilitation, right? So importance of upper limb, and you know that, is that they are really implicated in the self-dependence, and also the quality of life. So when a patient comes to the clinic, one of the first goals that you plan in physical therapy and occupational therapy and so on is just regain of the functional use of the upper limb. So useful, we will be back to this afterwards, but we believe that useful reorganization, all the literature points to that. We have more and more evidence for that. Is that cortical reorganization of cortical areas occurs in response to active exercises and to motor and attentional inclusion of the affected arm. I'm also particularly interested in this part because its recovery of motor function is not only motor, but also I think that it is also attentional. Hopefully, in the future, we'll be working on that. Also, right, Belen? And of course, physiological and anatomical changes have been described in almost all the areas of the sensory and motor areas of the brain. And this is why virtual reality is an interesting tool, because it allows us to provide specific interesting experiences to each participant's need, and to provide feedback and in other words, satisfying the moral learning theory or the moral learning principles, which, I mean, probably we don't find them all in a book or something like that called like moral learning principles, but when you go to the literature, you can say that exercises based on some principles are thought to promote or to better promote functional recovery of upper limb, and I can tell you that not only upper limb, but whatever, to promote learning, I would say. And some of them are enriched environment and intensity, and you want repetitive exercises, adapted on difficulty, providing feedback, motivated, specific, oriented to task, variable, which are not included here. So basically, when we design our systems, we try to maximize or satisfy these principles. This is what we did. So, because in coming back to Paul's question, this is what we did. I mean, we don't know what it works. We know that if we satisfy this, then we have some effectiveness in the treatment, as we have in the physical therapy. So when we design a virtual reality system, we try to promote what works in in physical therapy. The brain doesn't understand what is physical or what is virtual. So, but it kind of reacts and reorganizes when this is satisfied. So basically, what I'm going to present is a clinical overview of three different technological solutions to target rehabilitation of upper limb deficits of different severity. So I was going to do the talk like going from mild to severe, but after the talks yesterday, I decided to change a little bit. So I will start talking about moderate hemiparesis, and I will be doing connection with the previous talk. I will try to do that. In this case, we developed, probably most of the research on upper limb rehab has been done for this kind of deficits. I think that probably these patients are particularly interesting because they still have a lot of room for improvement, as the deficits are moderate, but still have a lot of room to improve. So most of the efforts have been done in research to these patients. I think that probably the studies with the RGS are more focused to this kind of population, and also our research will focus on this population. For targeting these deficits, moderate deficits, we implemented a mixed reality system. I don't know if it's a mixed reality or augmented reality. I don't know the fancy word here, but I don't know if it is an augmented reality or of a augmented virtuality. You can decide yourself. I will call it mixed reality, which was based on the moral learning principles that I've just presented before, to promote the rehabilitation of task-oriented movements of the paretic upper limb. And what we did was something like this. The main idea behind this was to come up with a system that I can put on a table and transforms any table in a rehabilitation environment. So basically, it's a projector pointing towards, which projects a virtual environment. This is back in 2012, I think. So we only have the Kinect 1. Actually, this is an Ixion Pro, but it was like the twin camera of the Kinect 1, and also in just a PC. So quite simple. I mean, not really complicated. So the idea was that, I mean, was having something really portable, with not too weight, so we can use it in the clinic or even at home. Something that never happened because, and this is a spoiler, because it wasn't the crisis. Remember the crisis? Now we're out because now we're rich again. But if you come back some years ago, we were in a crisis, and we suffered a lot. So some of our staff was gone, and we lost of knowledge. So the system collapsed, and we were not able to build it again. And now, after with the final slides of the presentation, I will tell you some good news. So basically, we had this system. We made it work. We used the depth information of the camera. So as you know, and because you have the same problem, the Kinect does not provide the tracking. I mean, it was originally created to have the tracking like in frontal. So when you just tilt it upwards, so it doesn't. The tracking doesn't work. So basically, we had to create our tracking algorithms for upper limb, for upper extremities. So we segmentate the images to identify the different objects, and also the hand, and also the forearm and the arm. It was quite a lot of work, but we came with something that somehow worked, with not very accurate, but it allows us to detect participants' movement and to provide them feedback, so interact with the system. So basically, we plan we plan different exercises and we always do that. I mean, because it's a question that has come before. How many variability do you have to include in a system? So I don't know. But what we do actually is given a range of exercises, because we know that motivation is really important, and patients will be with us like for sometimes for years, and motivation for us is really important. So we always provide them with different exercises, and also they allow us to train different or a wider range of movements. And this is what we did here. We tried to come up with some tasks that were likely to be presented in the motor repertoire of the participants before the onset. And we came to different exercises that allows us to train different movements. I have videos of some of them, so we will be watching them. But basically, all the exercises train the flexion and extension of the elbow, mainly the flexion and extension of the elbow, and also the wrist. We were not able to train the finger and the hand dexterity as much as we wanted, because for the technological issues with the Kinect, so we didn't have that accuracy. The accuracy needed for doing that. So we are not only allowed to interact with movements, but also with tangible objects. This is one of the things that we were really interested in. So we were interested in working on a table. So we use the table to allow us to counteract the effect of the gravity, as the Armio does. But we don't have an Armio, so we have a table. And basically, it allows us to rest the arm on the table. So it is easier for some of our participants, of our patients, to move the arm, because they don't have to counteract the effect of gravity, which is something difficult for some of them. And we also wanted to work in this plane, because we're really interested in working or in training the visual motor skills in the hand vision system, right? So we did something like this. So as you know, the system was kind of simple. I mean, not a really fancy stuff, you know. And the user interaction, this is, I mean, this was one of our developers. So we did tasks for tapping. Of course, you can do the buttons as large as you can. You can remember, I mean, numbers of different lengths. You can plan the time that you have to press the button. Same thing here. You can decide, you know, the length of the trajectories, the time that you have, time between objects, and so on. So you can work with different, I don't know how to say that, with different objects. So we had 3 different kind of objects to be grasped. Also the breast, flexion and extension of the breast. So what I'm recording is just from upwards, right? So you understand that. And also the, you know, finger, flexion of the fingers, of the metacarpophalangeal joints, but with maintaining the others in the same plane. And I think I have some videos, yes, of all the exercises, so I can go through them. But this is like a really gross movement with the shoulder and elbow involved. The grading exercise. So basically you have to do different recipes by grading this kind of chocolate and so on. Sorry. The doors exercise, the same. This is particularly interesting. It allows you to train the metacarpophalangeal, interphalangeal flexion extension. So you have to go to some water and then to squeeze it in a cube. The telephone exercise, you know that, and also the piano, and so buying things. And this is, I mean, they are patients, so they are patient training, and this is the way they train. I mean, so you find patients with different severity, and some of them are really good. I mean, this one can do it really fast. We provide, really simple feedback, extrinsic feedback about the repetitions and the personal record and the time that they have until the end of the exercise. And we plan a small study. Well, I mean a longitudinal study with in Valencia with the kind of participants that I was talking about. Is moderate hemiparesis. We involved 30 of them, all of them chronic, in an ABI study, in such a way that they train in physical A, they train where they undergo physical therapy, and in phase B, they train with the experimental system that we built. In both phases, sessions were 45 minutes long and were administered between 3 to 5 days a week, quite intensive, and each session consisted of 30, each phase consisted of 30 sessions of physical therapy or the experimental intervention. Conventional intervention included, passive assisted exercises, muscle toning, strengthening, persists exercises, and so on. And we assess them with a battery of clinical scales that assess the body structures and functions and also activities. 4 times, like before and after of each phase. And what we have was that we did not any change in the body functions. As patients were chronic, we did not expect it too much. We have a tendency in the Fugel measure that I can't explain, so I don't know what these patients did not have a statistical, at least, relation improvement between the start of the phase B and after the phase B. I'm assuming that was this kind of patient because I can't explain otherwise, because they improved in the other scales that assess the speed of the task and also the manual and shoulder and elbow speed is the box and blocks test, and the 9-hole peg test, and also in the quality of movement and the amount of use of the arm. So, and it happens, if you see, with statistical significance from the beginning to the end of the experimental phase, but usually not in other phases. So what we kind of prove is that probably the experimental intervention was able to provide a higher improvement in the activity of the hemiparetic arm, which was evidence in most of the scales. And again, it should be highlighted that the improvement was achieved in a chronic sample, where improvements are not or cannot be derived from the endogenous neuroplasticity processes, so they should be caused by the intervention. And this was one of the our most favorite systems, I have to say. But as I was telling you, it collapsed. So when we were in the middle of a randomized controlled trial, then it blew up. So research is like this, and we were not able to come up with the system again. So good news are that we are working on the new version of the system, like 5 or 6 years ago. So we are now including new tracking algorithms using deep learning techniques. I know that there was a talk last week, I think, on deep learning. So some of these techniques, but applied to the field of computer vision. So we are using some of them to build a tracking system that allows us to detect without the use of any wearable the forearm and the arm, and also shoulder, the hand, and also the full joints of the hand, which works quite well. Now we are running a reliability study which try to assess the accuracy of the system in comparison to OptiTrack system. And this week we are also starting to incorporate the Microsoft Azure, the new Kinect to the system. That it seems, it works quite well. I don't know if you have tried it. I know that you have that in the lab. The tracking algorithm finds well, but we will have the same thing. That it's not thought to work from an upward plane. So I think that we will be forced to work with our tracking algorithms. And in this case, the system will recreate just cooking tasks. I don't know if you know the Cooking Mama game. I don't know the games. I'm very bad at it. And I'm teacher of psychology of video games. But I don't know. I'm a very bad player, and I don't know the game, so I'm quite older. So I know all the stuff from the 80s. So basically, we are recreating cooking tasks with a wider range of exercises. So I have an alpha footage of the system that maybe we'll be able to show how the system works. This is projected, so it's not gamified yet. So basically, you have to make a recipe from scratch. So basically, you will probably need to wash your hands. Of course, everything should be adaptable to each participant's need. So maybe because some of them cannot supinate or pronate the wrist. So everything can be adapted. So you have to open the fridge, and then you have to probably take some vegetables, close the door, and then it was an egg. Okay, and then you have to freeze the egg, put some oil, and then turn on the I don't know what that is called. I don't know. And then put the egg, and what you are seeing is everything is virtual, but the thing is that we are also able to detect any object textureless, so we don't need any texture, and we can track any object within the with the system, so we can interact with real objects. For example, if we have to chop like this, we can use a real knife, I mean real or plastic knife, or we like in this case we may require participants to take, for example, one tomato and chop it with the other hand or with a fake knife or plastic knife, and in the virtual environment you will be seeing that some of the slices are coming. So we are mixing, reality and virtuality, but taking advantage of the tangible objects, because we're really interested in what haptics and what they can provide us, because it's another channel that sometimes has been forgotten in the field. So I'm very happy to see that in the previous talk, Dr. Burde has been presenting some systems also involving real objects, because this is what you have to use after in your real life. And this is the case of the moderate hemiparesis. Let me jump to mild hemiparesis. How is everything? Everything fine until now? Any question or no? Okay, very nice. So, sure.
I'm a little bit unclear about. You built a whole bunch of you built different interventions, right? And in some of the hidden inside these interventions are a number of underlying principles, right? That might or might not have a clinical impact, right? So, and also what you summarize is quite a few years of work, right? So which of these interventions has really given you traction now? What are you still using today, and then what were the most effective principles
for me
behind those? Yeah.
Believe it or not, I know that we try to do things based on research and what literature says. This is really important for us, but I'm tired of working. We have the Armio. I don't know if you know the games that the Armio has, but you know what patients love in the Armio? The chicken exercise, the duck exercise that I hate. So they loved it just because it's a duck. So, so one of my points is that, of course we have to have intensive exercises and repetitive. Really important to adapt each exercise to each participant's need, because they are different. And this is not I'm happy to see that you can do that in RGS, but this is not that common in in other systems. But one of the things is motivation. And this is one of the things that we have left. I usually thought when I attended the conference is that okay, another freak presenting another system, and I'm tired because all here we are presenting our systems, and I was just interested in the clinical effectiveness and so on. And now that I'm in the clinic, I can see that motivation is really important, because that would make patients to be to train more intensively. Also, you can also plan their therapies, but they will be doing better if they are motivated to do that. So provide them with a coherent task that is really amazing. And this is something that we can do with virtual reality or any other.
And to individualize also actually is linked to motivation, right? Because you want to give people the right level of challenge.
That's it.
Otherwise, they disconnect very quickly, right? So this is strongly tied to the motivation issue.
That's it. Because some of the people, you can see that a lot of research has been done with, computer games like the Kinect Adventures or the Wii Balance Board and so on, and they are fantastic systems, and I love them. And if your sample, if your patients can benefit and can interact with them, they are absolutely fantastic, but might not. So probably some of them won't understand what is going on, and some of them won't be able to perform what is needed in the exercises. So it's very it's absolutely necessary to adapt the difficulty of the task to what each patient is able to do. And you have a lot of studies, beautiful studies with the neuro studies with monkeys of the, making the plates smaller and smaller so to promote plasticity. But if you don't provide challenging tasks, just forget about plasticity. It won't happen. So repetition, the mere repetition is not sufficient. You need to adapt the difficulty of the task.
Well, actually, Martina has a
Sure.
really nice meta-analysis in NNR, came out earlier this year. It also showed these off-the-shelf games you buy at MediaMarkt are not effective.
Yes, of course.
But the VR interventions do work, and also they're specifically designed
That's the point.
for these interventions. That's an important issue here.
That's the point.
Yeah. So there are many things I like about your system based on projection, the augmented reality one.
Yeah.
One that I want to emphasize is that you are able to combine it with real objects and to provide physics, right? Like, and haptic feedback and so on. But something I'm concerned about it as well is that, and we have faced this problem many times, is that some of these patients do not have distal function, right? So I guess you found a lot of cases of patients that you wanted to include and you couldn't because they were not able to grab the object, the tracker. So do you have any idea of how to solve this, or how we will manage to find an alternative method to include also those patients?
Yeah, and the answer is virtual reality. So each one of the exercises can be tailored to each patient's capabilities. So you can say, okay, this patient can grasp an object like this. So he or she will be able, or will be required to take the real object for the task. And the others, I mean, they have to, if they have like proximal, I mean, quite proximal to distal movements, so they can flex the elbow to bring the hand over a virtual object, that would be enough. So the object in that case will be virtual. No problem at all. As long as the hand was over the virtual object, I will understand that he has grasped the object, right? In some cases where the patient is able to grasp it, I will require them to grasp the real object itself. Yeah, okay. Okay, so I think we can jump on, I mean, we can go to the mild hemiparesis. I mean, I think that, I mean, they have been like kind of forgotten in the research because, I mean, you are quite good enough. So, I mean, you can train in occupational therapy and so on, but they still have some room for improvement. So I'm also happy to see that some of the systems that you were presenting are also requiring some really, I mean, difficult movements to be performed, like doing like ulnar and cubital rotations and pronations, and also analytic flexions of the finger, which is quite difficult. So we wanted to focus for the first time in these patients, and we also were interested in the multi-touch technology as it is really accurate. And the last year, for 1 year and a half, we have been developing an app on a tablet, so we can train the hand function, mobility function, and hand dexterity. I have a video here that shows the exercises. So we have been based on the same principles. We look for intensive exercises, adaptive in difficulty, motivating. I mean, that provide unique feedback, a fast feedback about what you have done, motivating, and so on. So basically, you can train the tapping, which also, I mean, because depends on the way you train. I mean, if your elbow is fixed, you can train the tapping. If you leave the elbow free, then it's more, I mean, general movements of the arm. You can also train the finger. I mean, it's the finger pincer. The pincer is the correct word to say the pinch. The pinch. Okay, I'm sorry. So you can also train the pinch. The pinch was really interesting for us. So we made 2 different games. So basically, you have to reach the items, the Plateau items, these things, the plasticines, and then move them towards this friend here. Of course, everything can be tailored. We have, at the beginning of the game, as you have seen, we ask the participant to perform the pinch that they are able to do. So we adapt everything to what the participant is able to do. Let me jump a little bit, because I don't know how much time we have. No, I can't jump. Let me sit. Are you? Yes. Let's say if I can. No, I would like to move the video forward, but somehow I can't.
Well, something's happening.
Yeah. Yeah, apparently I'm able to do, the last virtual reality things and so on, and I'm not able to. I'm not able to run the video in my own laptop, which is crazy. So, but it's okay. But I can show you other exercises here. So no, I mean these are real patients in the ongoing study. We are running a randomized controlled trial. I mean to determine the effectiveness of the system. This is a real patient. As you can see, I mean, these patients are really, I mean, they are fine. I mean, what you can say. So, mobility is good. They are even able to touch with different fingers. We also have exercises for analytic movements of the fingers. He can also perform pinches quite well. The system is quite adaptive. It responds quite well. Provides good feedback of the movements. So, I mean, as you can see, the intensity is, it's quite intensive. So the exercise is quite intensive. So you can adapt anything to promote this. Let's stop this. Another one to train the pinch. So some items come, and then you have to bite them with the shark. I mean, the metaphor is not what is interesting, at least, I think. And this is another one. This is a runner, the typical runner, that is used to train the cubital and ulnar deviation. So basically, you have one runner here, one animal here, so you have to maintain them, within a road. I can move forward, but as you can see, this is happening at the same time that is, this is happening in the clinic in a real session. So we have another patient here who has been told to probably write about what, I don't know why. What had you been doing in summer? I don't know, right? So, but what I was saying is that, what I try to do, or what we try to do, is just to have technologies that can be integrated in the clinic, because this is our goal. We not only do research. This is what we did in university. What I'm asked for in the university, but in the hospital, I'm asked to do something that can work this way. That can be integrated in a occupational therapy session or in a physical therapy gym. Without requiring a lot of space or money or invest, right? Okay, so I only have preliminary data of the study, and until now only 9 individuals with stroke. I only analyzed 9 individuals with stroke. I think that 2 or 3 more have finished, but we still need like 7 or 8 participants for the randomized controlled trial. These participants have mild hemiparesis, and as you can see, at least it seems that everything is quite promising. Because it seems at least to provide benefits. I don't know if it is comparable to physical therapy. This is what I'm trying to assess to determine with the randomized controlled trial. But at least it works. Somehow it works. I don't know if more or less than physical therapy, but at least some kind of improvement. The system is able to provide it.
Is there some sort of control condition here?
Is a what?
Is there some sort of control condition we can compare this to?
With physical therapy. They are combining physical therapy with the tablet,
Okay.
and the other group is doing physical therapy alone.
Okay. So it's not like they do on specific tablet things.
No,
Right.
no.
And also on the tablet, you see there's a bit of a latency, right, between the physical movements and then the movements in the virtual environment. Is that an issue? Do people get confused? Because it might lead to errors in these avoidance tasks. Right?
Very good.
Goes up. So did you notice any problems with
If the task was really specific, I would say absolutely, because we know that actually. When we work with this, I mean, this is like a lag thing of a tablet that can be solved with another tablet. But in the video, you can really appreciate that. For the patients, I mean, they don't really appreciate the system, but we should be providing that, because I mean, we know that it.
In our work, we have been very, very nerdy about making sure that we have minimal delays in the technology, because, for instance, if you want to individualize, let's say, the difficulty, the challenge, but then there's this unknown noise factor of frequency, right? And then, of course, it becomes much more difficult to have control over that measure. But we are very sensitized to it.
Yeah, and we should be doing. I mean, and I'm talking from the clinic to our research lab, because in the clinic usually we are not. I mean that. I would say that people are not that interested in that, and these things matter. So as you say, probably if I don't solve the problem, nobody told me anything, never, right? Because we have a system, it works. They can have patients training with that. But we have an issue here, guys, and we should be listening. I mean, from the clinical staff, this is but at least this is what I always do, is just to listen what more basic research is telling us, right? And this is something that sometimes is not done in the clinic.
We know,
yeah.
Actually, we were getting very nerdy about that.
Yeah.
Because we did a basic research study on motor adaptation, and we were seeing that implicit motor adaptation is not present when there is a lag, or when we suppress visual feedback, online visual feedback.
Sure.
So the mechanisms that are engaged for learning, probably cerebellar, in the case of motor learning in adaptation, are not engaged if there is lag. There is a threshold of lag.
Okay.
So that's why I agree with you. Like, we look at the basic research, and this is a good example that should guide these details. Yeah.
Well, the thing is, and this also goes back to Etienne's work, right? That if you say, look, it's all about control, it's about how the brain controls the periphery, then of course, and this control algorithm implemented by your neurons is trying to deal with the periphery, and it tries to deal with the periphery plus all this noise, right? And then it is always assessing, let's say, the controllability of the task.
Yes.
And if you have noise in how the task is implemented, this will reduce controllability, and that might then mean you might reach a threshold level, as extreme example in acquired non-use, right, where the brain gives up.
Yes.
And that's from that perspective that we are really very concerned with making sure that this cannot be a factor, or if it's a factor, we know about it, right?
Yeah. So, and we have an additional issue here. So, of course, that will be affect. I don't know from the data, so I don't know. So, but I'm speculating. So, what I'm sure is that it will affect to the task that you are learning, but we still don't know how this transfers to the, because I don't really care that patients can. I mean, I don't really care if they improve or not in the game. I don't really care about it. And I don't really care even if they improve in the clinical scale. So I want them to be, self-dependent, and I want them to open the jar and to take the jar that they were able to do that before. So, of course, if we are really interested in how they improve or how they learn a specific task, that will affect. And that will affect learning, definitely. I can't say definitely, I think. Because from the scientific point of view, I think that we're not allowed to do that if we don't do all the research studies. But we have an additional issue, that is how this affects to the transfer of knowledge, which is what we try to do in the clinic. But yes.
Actually, another comment. Before you showed you were not having structural changes in body structure.
Yeah.
But you were having functional changes.
Yes.
So we recently found we published in this lab paper in Journal of Neurophysiology, that correlation between Kugelmeyer and kappa improvement is functional.
Yes.
Seems to be present only during the first stage post-stroke. But then,
Exactly.
as the patient progresses to the more chronic phases, they do not correlate anymore.
They are chronic.
Exactly. So they may not improve in Kugelmeyer anymore, but this doesn't mean that they are not improving at the functional level.
Yeah.
Right? Because they are applying strategies.
Sure. Sure. And we have to count on that too, because that is because that also promotes improvement, and also counts for improvement. Yeah. And that is in the last, all the data, the one when you analyze all the data and so on. That's in one. Okay. So you had to publish it like 5 years ago, so I can use that study to to justify my results. Yes. Yeah. We kind of knew that, right? They were chronic, so we were not expecting that to happen. Yeah. Right. So, okay, just in the last part of the presentation, I will focus on severe hemiparesis. We were saying before that useful reorganization of cortical areas are believed to occur in response to active exercise and to the motor and attentional inclusion of the affected arm, but severe paresis can prevent active mobilization of the arm. So then, what we do? If my patient is not able to move, then what do we with this? Is there any room for improvement? Right? So, actually, I don't like to say traditionally because I don't know what traditionally is. I don't even know what conventional is. So, but it is true that some years ago, like when a patient came to the clinic and they have a severe paresis, probably you make some effort to improve the function, but okay, this guy is not improving, then I will teach them to compensate the deficit. Because what I really want is to be self-dependent and independent in the activities of daily living. And this is right. This is good, and this is what we're looking for. But as you know, synaptic connectivity is dependent on the use. This is something that Belen was referring to yesterday. The absence of stimulation of the arm, we know that it reduces the sensory motor representation of the arm in the neural circuitry in the brain. So it decreases the opportunity of for sensory motor progress. And we know that this is, we know that this happens like in a loop. So if you don't use your arm, your neural representation in the brain will be decreased. So it will leave you less capabilities, less room for you to recover. And then you will be decreasing the neural representation of the brain. So it's basically a loop that is called learned paralysis. It's also related with the use it or lose it. So if you don't use it, your brain will use that for another things. They will manage, right? So if you don't use your arm, then the neural representation will be decreasing. So you will be more, you have more difficulties to move your arm and to improve and so on. So to overcome this effect, we only have a couple of approaches in the clinic. So when a patient comes to the clinic, they of course has passive mobilization. This is we have to preserve all the joints that the patient has, but we know that the effectiveness of passive mobilization is quite limited. Nothing related to neural plasticity. Some interesting studies in the sensory afferent signals, but that's it. We have mirror therapy. You know what this is, right? So you can trick your brain looking at the mirror, who is placed occluding your paretic arm. So you can trick your brain by moving the other arm. So, and watching to the mirror to trick your brain to think that you are moving your paretic arm, but but you are seeing is the reflex of your good arm, right? And another thing that we have is motor imagery. So we can ask participants, okay, just close your eyes and try to imagine that you are moving your paralytic arm and you are doing this kind of movements and so on. There are different protocols for that, different studies, but what we know is that neuroimaging techniques, I mean, we know from fMRI studies that mirror therapy and motor imagery are able to elicit cortical activation in the contralateral motor areas of the mirrored arm. So it kind of could allow us to at least to preserve what is there, right? The residual net circuitry that is there after the lesion, it can allow us. Maybe it's not functional. I mean, it's not functional indeed. So the activation is not functional. It does not lead to a movement, but it at least allows us to preserve the neural circuitry available. So we have a question there? Yes. 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 Wait. Okay, because I can
speak up. Just go there.
Sure.
Sure. You can manipulate the variables in the scenario.
Yes.
Which can then simulate movement.
Yeah. Do you recall any study where the movement has been enhanced or augmented somehow?
No, what I'm saying is that you can do that, like, because you're here showing what are the options, right?
Yes.
And so that's definitely a way to go.
Yeah.
Well, it's one of the things we are.
Exactly. And
yeah. And some studies have been used to do like a mirror therapy, like virtual mirror therapy. That has been done.
Exactly.
And I mean, whatever is virtual or real, I mean, again, the brain doesn't understand what is real and what is virtual. I mean, you can trick it. I mean, it's an arm. I embodied that arm. I believe that it is my arm, and then so on. I mean, okay. So the brain mechanisms are, I mean, the same. I mean, with the accuracy that we can watch the brain is the same. Maybe it's not, but we can say the activity is quite similar. It's similar.
Yeah. Okay.
Yeah.
Berlin published a beautiful study where we do intention-compatible enhancement of movement, right?
Yes.
So give it a task, you know the goals.
Yes.
And then you can use that information to virtually enhance movement, right? This has been extremely effective for acquired non-use.
Yes. Right? So I will. That is perfect, because I would love to finish my talk like with this comment. When we have a patient in the clinic, actually we did this. I mean, we have done mirror therapy. I mean, the evidence of mirror therapy in moderate hemiparesis, it's I mean, there is something there, but it doesn't work in severe hemiparesis, and we have proved that. We have studied. So, and we didn't work. And motor imagery, I mean, it's quite difficult to perform this in participants with stroke. As we were saying before, in the beginning of the talk, that these deficits are really heterogeneous. So it's difficult to have a participant that he or she will have like motor deficit, but probably they will also have cognitive deficits, attentional deficits, and so on. So if it is difficult for us to imagine a movement, try to explain that to a participant with a stroke when you don't have any control of what is going on in their minds. So whatever is going or is happening there, we don't know. So it's really difficult to implement. To implement motor imagery protocols with post-stroke participants. It is really useful in sports, for example, where brains are healthy, really nice. And they can be trained, and it has been proved that motor imagery improves, the task. This has been done, you know that. So basically we have, mirror therapy with similar efficacy to passive mobilization, which is, very limited, and also is tedious, very tedious. So this is one of the things that patients really relate. And motor imagery, it's quite difficult to implement. And then we have some non-invasive brain stimulation techniques. Yes. Okay. There's nothing to hesitate, that's fine. Then we have some TDCS. So Belen told us yesterday that you have a beautiful TDCS study. And you know, the TDCS is really interesting for us because it can modulate, you know, neuronal excitability without any movement. So I can apply it externally. It can reduce the threshold for, you know, the recruitment of this circuitry, and this can be a potential technique that can also be applied to severe hemiparesis, where movements are not possible. This technique has been reported to promote cortical facilitation when it's combined with virtual reality. We only have like a couple, 2-3 studies combining virtual reality and TDCS. You know that, and again, it makes no point to defend what virtual reality can provide us here. But I mean, you can do whatever you want in virtual reality. So you can have, you can make your patient to see a virtual arm that is moving when he is not moving or she is not moving, right? And basically, this is what we did. So our hypothesis was that combining TDCS and a virtual reality-based intervention, we will have some cumulative beneficial effect on the sensory motor function in patients that are not able to move in severe hemiparesis. So basically, this is what we did. So we had a experimental system that provided audiovisual stimulation, also tactile feedback with some haptic actuators, own-made, and TDCS, transcranial direct current stimulation. And the system allowed interaction using eye tracking, like one eye tracking bar, that like the one that you have in specs here in the lab, and also from the residual muscular activity and movement, which was registered using the Mayo. So the Mayo, I don't know if you know the Mayo, but it has like, okay, surface EMG, nine sensors, and also accelerometers and EMU. So what we did is just to have a reaching task. So we have a virtual, I think they can jump over it. So basically, we recreated a task in the virtual world. So we have some apples coming from an apple tree, and then participants are required to grasp the apple and then to bring it to the mouth. And how they do this if they are not able to move. I mean, let me go back because I love this stuff. So we decided. I mean, we decided. You know this paper? You know Graziano paper, which is, I love that. So basically, we chose this movement because it's believed to be highly represented in the brain, at least in the brain of the monkeys. So Graziano applied like 1 second electrical stimulation to the brain of the monkeys, and he was like applying this current to different parts of the brain. He was scanning the brain and applying that current, and he found that some patterns of movements were more represented in the brain, and the one that were more represented was this one, like bringing something to the mouth. Another one was like trying to evade from an attack or something like that. So that motivated us to recreate a kind of movement that is based on grasping something and bring it to the mouth. And if you see a monkey, this is what monkey did. A monkey just can't stop eating, so they can eat like this. Ah, surprise! There's a little monkey. Yeah, that's my present to you. So they can't stop doing that. So basically, we based on that task to simulate this in the virtual world. So in the practice, participants were required to pick the apples, and for that they will have to look at the apple in the screen, and to perform or to intend the movement. And that intention, we calibrate each participant's ability to perform the movement. So we had the Mayo, and there was an apple on the screen, and we asked them, try to pick up the apple. So our patient tried to pick up the apple, and that gave us the surface electromyographic activity and also the accelerometers and the gyroscopes data. So we knew, the maximum data of these physiological signals of the surface abdominologic of the muscular activity and the movement that the patient was able to do. So in the practice, so in the exercise, if they were able to perform 80% of that value, if they were able to overcome that threshold, for us was detected as an intention to move. So actually they were not moving, but they were intended, when they were trying to move, right? So if they were looking at the apple, and we detected that it was an intention to move, we launched an animation, of course, of a virtual arm that was grasping the apple and then bringing to the mouth. And we were providing, proprioceptive feedback when the virtual arm contacted the virtual object, and also when it come to the mouth, right? And at the same time, we provided TDCS. Yes.
Was the arm visible to the subjects?
Yes, they were asked to see to the screen, but it was in the beginning, and then we used clothes to the what you are going to see in the video. There is one without the clothes to see what is happening, but in the practice they were hidden from vision. We tried to do it after the table, but I mean, as some of them were like presenting spasticity or something, we can do that. So,
did you use like head-mounted displays?
No, it was a laptop. Just
so why didn't you go for the head-mounted display?
because we also used the TDCS, and it was too much, and because maybe it was adding us another effect, and I didn't want to live with more things for the study. But that's something that maybe can be done. But for us, it was difficult for the TDCS. I'm sure that it can be easily done by doing, probably we use the NeuroSteam cap, so probably you can adapt it to have the HMD, in the same place, right? So, exactly. So interaction was facilitated by the eye tracking and also with the intention of movement. And we provided like audiovisual feedback and also tactile feedback and TDCS. This is a video example of how the system works. Of course, the system was able to be adapted for us to use it not in the clinical study, but if patients are not able to use it if they are not able to use the eye tracking, I don't know why. So you can always put a video, animations, and the system goes itself. So interaction was facilitated with eye tracking and the Mayo. And the system provided audiovisual, sensory, and TDCS. And users were required to stare at the apples and to try to move the arm. They were also, you can see that, this is the movement that they can do. This is the where electrodes are placed. It's M1, FP2, or M3. Yes, exactly. Like we were targeting. I'm confusing like C3 with M1, but we were always targeting M1. So the anode was placed on the M1 and the cathode on the FP2. Some research has been done. I don't know how you guys are implementing it, because I don't know if you are going to M1 or to the just prefrontal, right? Yeah, because there's no evidence what it works better, right? Yeah. Okay, so we run a randomized controlled trial in different units of our network. Our final sample has been like 29 participants. This is under review. So participants in the control, I mean, they were, of course, randomized in a control or experimental group. The control group received 60 minutes of conventional physical therapy, and the experimental group combined 30 minutes of this with the system and 30 minutes of conventional therapy. And we used 25 one-hour sessions, 3 to 5 times a week. And as I told Belén yesterday, this is probably the most amazing results I've ever had. Let me highlight something that I forgot to mention. One of the criteria that we had is that we require participants to have like haven't experimented any change in the upper limb motor function in the last 2 months. So there were patients really severe that were not responding to physical therapy, because all of them were were participating in physical therapy. So we asked them we were looking and we were targeting these people who are basically the non-responders to the physical therapy. And we experimented one of the greatest increases that we have had in my life as a young researcher, I say, like improvement of more than 5 points in the Fugel measure, and also, in the time and and ability of the Wolf motor function test, with a decrease of more than 100 seconds, and also in the improvement in the ability, and nothing interested, I would say, in the sensory domain. So we had huge improvements in the motor function, but nothing in the sensory domain. Do you know the Nottingham sensory assessment test? Do you know the scale? So it's because it's not really. It's not that common. Yeah. So it's probably one of the best scales to assess sensory function. So basically, you have different tests to assess the pinprick and the double touches and stereognosis and so on. It's quite good, but we never had any significant improvement in the scale as a whole, and just a small improvement with time in both groups. In the stereognosis and the tactile, but never superior to the physical therapy. Yes. Oh yeah.
Just a quick question on the age. This improvement was shown across ages because you have 35 and 60. So
Yes. Nothing related with age.
maybe I missed this. The control group was sham or was doing conventional therapy?
Conventional therapy.
Okay.
And now it leads me to another study I will tell you. Yes.
Movement, you have at least 2 phases, right? Like first reaching and then.
And then, yes.
So was any type of muscle activation enough to trigger the whole thing, or would you make the difference?
Just the intention of going.
At the beginning, and then it would, unchain the whole thing.
Exactly. Yes. Yes.
So, Reeves, you said, but how long was the therapy and how were the sessions divided?
Yeah, it were 25 sessions. Don't ask me why. It was decided like 25 because we have been used this paradigm in the previous study. So we wanted to follow with this because we know that it did work. I will show you afterwards. And our sessions ran from 60 to 45. In this case, they were 60 minutes. And the experimental group combined 30 minutes of physical therapy with 30 minutes with the experimental session. More than that, they were not allowing to more than that. It's not that motivating, right? They love that because I was really afraid because I thought that they were going to hate the system because it's really boring. I have to tell, but they will love it.
And day after day, or with pauses between the.
It was administered from 3 to 5 times a week.
Okay.
So we discarded participants who were attending like once a week or twice a week. And it was only applied to those who came like 3 to 5. And we have lost some data of, I think, 4 to 5 participants because it was summer and they decided not to attend to the therapy. So we have to exclude them.
Sorry, maybe I missed
They were chronic. Chronic. Super chronic.
How many months?
3 months.
6. It's always 6. But what I was telling Belen yesterday, well, let me. I will go back to the chronicity because it's a really interesting point. So basically, we know that the combining. Well, I mean, we expected that combining TDCS and VR could make the point. There is a little study that has shown that cortical exhibitability has been increased by using these two techniques together. Previous interventions support the improvement in this that has been detected in the body function and activities. But what I would highlight in our study is that our patients were chronic and they were really severe. So you don't expect too much. And the changes that we detected in our study were not only statistically significant. I mean, this is really important because it's the way that we can determine what is significantly relevant or not, but you can't tell that in the clinic. I mean, they don't really care about, statistical significance. I want to know if my patients improve. So I don't really care about statistical significance. And the improvement detected was higher than the minimally clinically important difference. And this never happened to me. I have never seen this. And that means a meaningful change. That means a clinical change. That means a clinical change for the patients. So the relevance of this study, I think, is that all our participants were chronic. All of them presented like severe impairment in their upper limb motor function, which indeed is the worst prognostic factor of upper limb motor recovery. So the worse your motor condition, the worse your progress will be. This is what all the meta-analyses say. The improvement overcome the minimally clinically important difference, and these results, which leads us to a really nice question we can discuss now or in the dinner or in the lunch or whatever you can, is that this study questions the existence of a rehabilitation plateau, because these patients were not improving at all. It was months without any kind of improvement, as described by the Fugel measure. But then you change the rehabilitation and the intervention, and they boom, and they experience a huge improvement. So this question, if this exists or not, I mean, maybe it's a matter of changing the intervention, changing the whatever the principles that the therapy is based on. Maybe you need more intensive exercises, more repetitive. And important thing is that we have 5 non-responders in our study. So we have 14 participants. When you look at the average improvement, the improvement is huge. But 5 of them did not improve at all. And when I say at all, I say nothing. Not a point in the Fugel measure, as they were doing in the physical therapy, in the conventional physical therapy. So what do you think, guys, it may be the case, maybe the cause of this absence of improvement? Yes? Yeah, we have all the data, and I can tell you that no demographical or clinical variable was different between these participants and the responders. Not the chronicity. That's it. That's it. I don't know that because I don't have a TMS. So I haven't been able to measure it. Hopefully I will have that in the following year, and hopefully I will have access to these patients. But I don't know, but maybe lesion to the tract of these patients would explain the absence of results. So then whatever you are doing in the cortex is not getting to the hand, right? And this is my hypothesis, I don't know, right? And actually, the integrity of the corticospinal tract is the second most important factor of prognostic factor. So one of them is the severity of your deficits. The better you are, the better prognosis that you have. And the second one is integrity of the corticospinal tract. Importance also is that preliminary studies have shown that maintenance of gains, that participants maintain the gains after the intervention. So this is just a longitudinal study with, I don't remember, with 7 participants, I think. Again, it was like an ABA, physical therapy, this system, and physical therapy again. As you can see, the improvement was the same, like a huge, more than 5 points in the Fugel measure, also in the Wolf motor function test. They were more increased ability and decreased the time, and the gains were maintained when they come back to the physical therapy. So they were there. So maybe we have found a way to, or another therapeutic options for the scant therapeutic options that these patients have, right? So just to conclude, we have seen that the severity of the motor deficits after post-stroke is really heterogeneous. Most of efforts have been done on moderate deficits and with promising results, I think. I think that the same theoretical basis that we applied to the rehabilitation of moderate deficits can be applied to mild and also to severe hemiparesis. And I think that technology can help clinicians, and with especially interested in virtual reality, to overcome the limitations of conventional therapy, whatever conventional means, or, for example, by modulating cortical excitability. So I'm really excited to see your results. Everything looks good, I think, or also by providing augmented movement feedback, which has also been done by you, right? And of course, I'm just a beautiful face for it, but my, important people are they. And thank you very much for your attention.